A very good evening, all of you. I welcome for this today's webinar on theory and practice of Mydriatics and Cycloplegics. I wish to invite Professor Monica Chaudhary ma'am to introduce our eminent speaker, Dr. Sumit Grover, for this session. Ma'am, please.
Thank you so much, Oli. Dr. Sumit Grover is an ophthalmologist. He's also done his management, and very recently he's done his master's in public health from London School of Hygiene. To me, as I introduce him as a good friend and a good friend of optometrist, he's been an educator who's been so keen not only to orient the ophthalmology, but has a passion and love for optometry. He's helped us set up a glaucoma screening center of excellence at our campus. And when the first thought came that we want to learn about cycloplegics and Mydriatics, he was so happy and to deliver the lecture. We all know this lecture seems to be very, very basic to all of us, and we've been doing it for years. But the reality is, even we may have read Borish or taught Borish. What I started practicing was whatever my professor was doing in the institution. So if my professor is prescribing or AIMS is prescribing this drug, I learned to do it. The theory behind it, how many of us are actually understanding what are the facts in it? So Dr. Sumit is here to bring you with real facts, with references to say, these are the cycloplegics, this is how it works, this is the time when you should be doing it, and these are the Mydriatics which it should be used. So I request you all to please mute your mics, be patient and listen. We will have a lot of discussions, and I'm sure many of you would have your own experiences and myths to share. Without going further, I'd request Dr. Sumit once again to join us, and thank you so much. We are really keen and looking forward to your presentation.
Thank you so much, Professor Monica, for such a kind introduction. And first of all, I'm glad to be part of this amazing lecture series. I want to congratulate and thank Mr. Ajit Bhardwaj, President of Optometry Federation of India. He's a great leader and as good as a great tennis player too. And I would like to thank Mr. Rajesh Wadhwa. I must say that all his presentations are my favorite. And of course, Professor Monica, Director, School of Health Sciences, Ansal University, and she's also a honorary patron of Manthan Eye Healthcare Foundation. And of course, Oli for setting up the stage and for his technical support for today's lecture. So I think we can start now. And the title of this lecture is Theory and Practice of Mydriatics and Cycloplegics. And I believe that I would be able to justify the title today. We'll cover both the basic theory and the practice management. What are the good practices we should all follow? So what are Mydriatics? Mydriatics are the agents that induce dilatation of the pupil. While cycloplegics, these are the agents which cause paralysis of the ciliary muscle, inhibiting the accommodation. But in the layman terms, we call them dilator. Ki dilator put kar do patient mein, which causes the widening of the pupil. But we should understand that there is a fundamental difference between a Mydriatic and a cycloplegic. And when we what do we call an accommodation? Accommodation in the eye is of, I'll split it into two things. The accommodation created by the lens and accommodation of the pupil. When we focus from a far object to a near object, our eye accommodate to focus on the near object. And how it does? In the lens become more convex. The ciliary body contracts, the zonules become lax, the lens becomes more convex, and the converging power of the lens increases. And for the pupil, the sphincter muscles of the pupil, they contract and they block the peripheral rays which are coming from the periphery or the cornea. So what happens? They remove the spherical aberration and increases the depth of focus of the near object. So this is the accommodation. And those agents which block these two processes, are known as cycloplegics. I think there is some problem in the, yes, now it has been worked. We'll talk about all of these drugs which are shown on the screen, which we all use, but I want to say that I have no financial interest, interest for the disclosure. These are just for the pictorial depiction of the commercial drops which are available. So I'll start with the basic anatomy of the iris. Our iris, which forms the pupil. Iris has stroma. Iris has, apart from the stroma, iris has two muscles. One is dilator muscles, which are radially arranged, and the sphincter or the circular muscles, which are arranged circularly, right? And the neural system, which innervates the iris, is of two types: the sympathetic and the parasympathetic. Sympathetic pathway comes from the hypothalamus through the ciliospinal center of Butch to the superior cervical ganglion and innervates the radial muscles, the sphincter muscles, and the neurotransmitter here is noradrenaline or norepinephrine. While the parasympathetic innervation is through the pretectal nucleus from Edingle-Westphal nucleus via the third cranial nerve, which is oculomotor nerve, which synapses into the ciliary ganglion, and post-ganglionic fibers from the ciliary ganglion reaches the sphincter muscles and affects the M3 muscarinic receptors. And the neurotransmitter here is acetylcholine. I'll stop here and we'll again come to this slide, but the basic thing I want you to remember that the pupillary reaction or the muscles are under the autonomic nervous system control. Parasympathetic, the neurotransmitter is acetylcholine. The receptors are muscarinic receptors. For sympathetic innervation, the neurotransmitter is noradrenaline or norepinephrine. They innervates the radial muscle. Now, what are the indications for dilatation? Routine examination of all the patients. American Academy of Optometry guidelines say routine examination of all the patient requires a dilated fundus examination. Especially for patients aged 40 years or older, comprehensive eye examination is recommended annually, even in the absence of any diagnosed ocular condition. More frequently, monitoring with dilatation is indicated in patients with previous ocular pathology like high myopia. And why high myopia? Because we all know in high myopes, there can be some treatable lesions like lattices, holes, or maybe some breaks which are silent. And by dilating, we can see the periphery of the retina and we can timely intervene and do the laser barrage, etc. Then patients with systemic conditions like diabetes, mellitus, and hypertension, we should always dilate them. Why? We should explain them that they can have ocular complications like diabetic retinopathy, hypertensive retinopathy. So they have to have a dilated fundus examination. This comes under the opportunistic screening of these ocular complications of these systemic conditions. Now, if the patients in your clinic comes with the symptoms and sign indicative of intraocular diseases like flashing lights, this can be a sign of impending retinal detachment. Floaters, sudden floaters may be a sign of posterior vitreous detachment, or maybe in elderly patient, it could be a sign of retinal detachment also. Reduced visual acuity may be a sign of BRVO, branch retinal vein occlusion with macular involvement, or maybe CRVO or optic neuritis. These all conditions demand dilated fundus examination. Apart from that, they have some diagnostic and therapeutic indications. Cycloplegic refraction in children, especially small children. We all know they have much more they accommodate than adults. So their accommodation masks the refractive errors like hypermetropia. So in what happens in hypermetropia, the eyeball is small and the rays which are coming from the infinity, they converge behind the retina, but the child accommodates, converging power of the lens increases and they converge the light so that they fall into the retina. But these accommodation can mask hypermetropia, the latent and the facultative and the manifest hypermetropia. To reveal that thing, we need cycloplegic refraction. We need dilatation for ophthalmoscopy, lasers if we want to do posterior segment lasers like pan-retinal photocoagulation, or before the cataract surgery, we all know. They have some therapeutic role in amblyopia therapy. We all know penalization by atropine. In an inflammatory condition of the eye known as uveitis, hometropine is the drug of choice. The mechanism of action is by doing the cycloplegia of the ciliary muscles, it removes the ciliary spasm and make patient pain-free. Also, it prevents because the iris is infiltrated with the inflammatory cells, it is muddy, it is reactionary, so it prevents the synechiae formation. And we all know myopia controlled by low dose atropine. Although I have just mentioned this, and if you just take note of any of these, and if you want to discuss about the role of atropine in myopia or amblyopia or whatever this thing, we can discuss in the later part of the lecture. Now, contraindications and precautions. Medico-legal litigation varies from country to country and type of practice, like you are a solo practitioner, independent practitioner, or you are in a group practice, or you are under the supervision of a ophthalmologist. It varies. And I think the best resource person here is Mr. Rajesh Wadhwa. He can guide us that what are the medical litigations associated with use of these drugs. As far as I know, you cannot prescribe even the low dose atropine without the consent or the supervision of an ophthalmologist. While about the cycloplegic and Mydriatic, Mr. Rajesh Wadhwa can throw the light on us. We should be careful about, like any other drug, like any other oral or the topical drug, they can also have allergic reactions, phenylephrine, cyclopentolate, and sensitivity to the preservatives like chlorbutyl. If you see the vial of a tropicamide or phenylephrine or any other dilator or cycloplegic drug, you will find a chlorbutyl preservative. It is very notorious to, induce the allergic reaction in patients. Narrow anterior chamber. If you see that von Herrig grading shows you that the anterior chamber depth is very low, or you find occludable angus and gonioscopy, do not dilate, refrain from dilating. Presence of iris fixated intraocular lens or the anterior chamber IOL. The risk of IOL dislocation with pupillary dilatation does exist. Before gonioscopy or any procedures like laser PI in glaucoma's patient workup, I have my own personal experience that the optometry staff, or in fact the junior ophthalmologists, they are so much conditioned that if the patient has come, we'll have to dilate before showing it to the senior. They just think over to the spinal level. They don't think to the cortical level. We should think what we are doing. Before doing, we should think that if the patient has come for the gonioscopy or the laser PI or any other glaucoma workup, we should not dilate the patient. And that is the difference between a learned eye healthcare provider and a non-learned eye healthcare provider. Documentation of the pupillary status, very, very important. I think this is the most important take-home message, and I have marked it red. Always assess and document the pupillary reaction before dilating. Assess both direct and consensual right reflex. I hope everyone should know. Direct is when we throw a light into the right eye, the pupil of the right eye constricts, as well as in consensual, the left eye is also constrict because of the ciliary ganglion and Edinger-Westphal nucleus. The neurons cross over to the other side. Pupillary status is a very important vital sign in patients with any intracranial pathology. Dilate with care in patients with recent history of any head trauma. Unilateral pharmacological mydriasis may masquerade as a sign of intracranial diseases like Hutchinson pupil, or I think this would be covered in the next part of the session where Dr. Rashmin Gandhi will elaborate more on Argyll Robertson pupil and these neuromuscular disorders of the eye. And some prescription medication as well as some recreational drugs can also cause people to dilate or constrict. And these have some medico-legal implication if you don't take history before dilating. do not document the pupillary status, you may have some medico-legal repercussions. And we'll see what are the prescription medication. These are medications basically which are parasympathetic. Acetylcholine is a neurotransmitter which is associated with the parasympathetic control, and these are used in some medications for Parkinson disease, and as well as before surgery to maintain the body's function under anesthesia. Apart from that, antidepressants like fluoxetines, these are selective serotonin reuptake inhibitors, very commonly used. Antihistaminics like antiallergics, benzodiazepines, decongestants like Dramamine, some motion sickness drugs, muscle relaxant used in anesthesia, and some earlier versions of anti-seizure medications like phenobarbital cause dilated pupils. Some illicit or recreational drugs. I wonder always that why these are called recreational drugs. What kind of they recreate, I don't know. They cause mydriasis, and the examples are amphetamines, which are stimulants, bath salts, cocaine, crack cocaine, ecstasy. Ketamine is a anesthetic, LSD and mescaline. And honestly, I don't know about details about, I just want know the names, and I believe that you also don't. I'm happy if you don't know the names of these drugs. Then opioids are the drugs which constrict the pupil. The common opioid medications include codeine, hydrocodone, and these are very common drugs. You will find them as a constituent of many cough syrups, which are used for the dry cough. Morphine, fentanyl, which is again a muscle relaxant used in anesthesia, methadone, and some illegal form of opioid include heroin and opium, which are, I think, very common. Now we'll come to we have touched somewhat of a theory. Now we'll come to the practical clinical consideration. We should always consider the side effect of mydriasis. We just put an eye drop in the patient and we do not consider about the side effects, blurred vision, especially for near work, for reading, office work, photophobia, decreased ability to recognize low contrast hazards and vision performance during the driving, increased glare sensitivity. These can contribute to angle closure event in patients with narrow anterior chamber, as I explained previously. So the patient should be advised accordingly. If the patient has not come with the attendant, so patient should be explained that if you have not come with the attendant or you have come with driving some vehicle, so there might be some problem. Counsel the patient and always take an informed consent. Other thing is that sometimes the people like they get frustrated that I have put so many times the drug and the patient is not getting dilated. So the light color eye dilate faster and more completely than the darkly pigmented eye, because the iris pigment sequester the drug less. Then individual with poorly controlled diabetics, because of diabetes affects the small nerves and vessels. Increasing age also causes miotic pupil and increased latency time to dilate, as well as injury to the brain and intake of certain drugs, which we have discussed just now, can lead to abnormally dilated or constricted pupils. It's a small bit of a practical tip that before dilatation, we can use a local anesthetic, which is proparacaine. This anesthetic decreases the blinking and tearing and changes the permeability of the epithelium to the mydriatic agent. It also reduces any burning sensation, so the patient will be more cooperative to you. But be cautious that these drugs can cause dry eye changes and epithelial toxicity, and never ever give these drugs to your patient to put unnecessarily. They are very dangerous. Now, after having known all these things, I think we should have our own clinical considerations, and we should develop our own best practice and standard protocols. So we should take a good history, visual acuity, pupillary reflexes, intraocular pressure, torchlight examination, or the slit lamp examination, which is best, and the anterior chamber angle. Recording and documentation is very important. Record the name of the pharmaceutical agent used in, including its concentration and time of the day. Counseling and consent is very important. And always wear a smile on your face when you are counseling and taking consent. Now, again, I told you that we'll again come to this diagram. And the reason is I want you to again revise that the parasympathetic nervous system has acetylcholine, M3 receptors, and sympathetic have adrenergic receptors and the receptors, and the neurotransmitter is noradrenaline. And we have agonist drugs, parasympathomimetic drugs, which causes sphincter contraction, causing meiosis. An example is pilocarpine. Antagonists are anticholinergics, parasympatholytic, and there's also called anti-muscarinic. There are three names. They bind to these M3 receptors, causes pupillary sphincter inhibition, and causes mydriasis. They cause ciliary body inhibition, leading to cycloplegia. Examples are tropicamide, cyclopentrolate, and atropine. And there is a very important and very good acronym I found. STOP ACH, scopolamine, tropicamide, atropine, cyclopentrolate, and hometropine. I found it very useful. Then there are direct alpha adrenergic agonists. They bind to directly to these alpha adrenergic receptors. This one, this receptor, and causes the dilatation. Example is phenylephrine, and this is a very classical, a diagram which you'll find in many of the textbooks of ophthalmology and optometry, where you will find their concentration peak time, recovery time, and the washout time. For atropine, it's the longest. For tropicamide, it's shortest. And for cyclopentrolate, it's in between, and that makes it an ideal drug for use for the cycloplegic effect. Now, what are the goals of our treatment? To deliver a full dose of drug to the patient without any systemic exposure, with patient safety and comfort. Preliminaries are patient education. It's not like कि कोई patient आया, आपने उसकी आंख में सीधा दवाई डाल दी, और वो भी बिल्कुल gently नहीं उसकी आंखों को इस तरीके से कर दी. No. Explain the purpose of the procedure. Inform the patient that you are going to instill the drops. Wash hands, especially in the COVID times. Use gloves. Inferior fornix method is when you just pull the inferior fornix like that, tilt the head backwards and retract the lid and put the eye drop into the inferior fornix. And be gentle and be empathetic with the patients. And as I already mentioned, that if you use anesthetic eye drops, it decreases the patient discomfort and maximize the drug penetration through the cornea. The solution in suspensions and inferior fornix method, it's a preferred method. It maximizes the ocular contact time, minimizes the drug loss, increases ocular absorption, and decreases the systematic absorption if we tell patient to close the eye or we ask patient to do the punctal occlusion for 2 to 3 minutes. Apart from that, subconjunctival infection, many of you may be knowing that we use midricaine. It is usually used for the advanced uveitis, where there are posterior synechia have developed. Other low anxiety techniques are medial canthus delivery, where we put the drop into the medial canthus of the anxious patient and tell patient to blink so that the drop spreads. Spray bottles, unfortunately they are not available commercially in India. Cotton swabs saturated with the drugs. But these methods have some disadvantages, like you cannot meter the dose, and the wastage of the drug is very much high in these low anxiety techniques. Now, how do you assess that the completion of the cycloplegia has occurred? A common perception, the common learning is that when the pupil is dilated, that means the cycloplegia has occurred, which is not the case. The mydriasis and cycloplegia do not complete at the same time. Study says that unlike hometropine and tropicamide, in the case of cyclopentolate, the cycloplegia is completed prior to mydriasis. I wrote it's about 30 minutes as it was suggested by some study. But in practical thing, and if we read the Borish book, which is the gold standard, it says around if you put cyclopentolate, you should do the start the cycloplegic refraction at least after 1 hour. So if the pupillary dilatation is used to determine whether the cycloplegia is at the level of refraction, the refraction may be unnecessarily delayed or additional drug may be used unnecessarily. There will be wastage of drugs. We'll just put the drugs again and again. So how do we assess? We can assess it by the residual accommodation by the push-up test. I think, I believe that we all know what is push-up test. Push-up test can be done by the pencil push-up test, and if we want to be more standardized, it can be done by the RAF ruler, which is Royal Air Force Academy ruler. Then now we'll come to the individual drugs one by one. Tropicamide is a drug of choice for routine mydriasis, fastest onset, shortest duration of action, equivalent mydriatic effect of 0.5% and 1%, but greater cycloplegia comes with 1%. Commercially, it is available as 1% as well as in combination with phenylephrine, 0.8% tropicamide and 2.5% phenylephrine is most commonly used in India. Side effects are stinging upon instillation, which can be decreased by using the paracaine or the lignocaine before its application. Contraindications and precautions, no reported adverse systemic effects have been seen, though many of the preservative like chlorbutyl I've already explained can cause severe allergic reaction. It's very notorious. And I want to stress this point that if the patient comes to you and the patient has developed the signs of allergy, do not panic. Refer the patient to some health facility to get the injection of F-choline or hydrocortisone, which are anti-allergic, and ask the patient to wash the eyes and always mention with a red bold marker on the prescription of the patient that patient is allergic to tropicamide or this cycloplegic drug so that again when the patient comes to some other health facility or eye facility or other eye healthcare provider, they know that the patient is allergic to this specific drug. Hometropine, clinically it is used as 2% weight by volume, used for cycloplegic refraction in older children, but its most important indication is treatment of uveitis. Its weak but prolonged effect and strong mydriatic effect makes it suitable for uveitis therapy. As I've already explained, that in uveitis, it causes a pain relief and prevent the formation of synechiae of the iris, posterior synechiae as well as the anterior synechiae of the iris. Then atropine, it's the most important mydriatic cycloplegic which is available. When complete cycloplegia is needed, we use atropine. It is used as a 1% ointment in children and it is commercially available as 1% drops or ointment. Clinical use of refraction, useful in case of suspected accommodative esotropia, especially in young children. In my practice, we always do the refraction of the child if below 2 years or maybe under 4 years of age with atropine. It's a best practice which is followed in our institution. And if somebody has, on uncover test, if you find that the patient has convergence or you suspect the accommodative esotropias, then definitely do the cycloplegic refraction under atropine. Also, the therapeutic therapy, penalization of the better seeing eye is done once a week. Installation of atropine is done to blur the image in the better seeing eye. And the studies, ATS study and amblyopia treatment study shows that it is equally efficacious as the patching. And I previously described that low dose atropine is also used for myopia progression control. Atropine toxicity, although rare, but can elicit with the following symptom: dry mouth, usually the first sign, fever, dry flushed skin, rapid pulse, disorientation and fever, and in fact CNS things. And though rare, but not uncommon. Two, and in the literature, if we find there are 3 episodes of death due to systemic absorption of atropine drops. But they also say that those children who unfortunately died have some or the other systemic underlying systemic condition. But we have to be very, very cautious if we use atropine. And now there is a question for the audience. You can, in your chat box, you may write the answer that what are the guidelines or what are the suggestions we give to the mother or the attendant of the child when we prescribe the atropine. And we always prescribe the atropine ointment and not drops. I think it is self-explanatory because atropine ointment has low chances of systemic absorption than the eye drops. And what I want to hear from the audience, that what advice you give to the mother. You can use the chat box. I give you half a minute for that. Now I'll tell you that what suggestion or what advice we give. Usually we give atropine 3 times a day for 3 days, and we advise mother to take the atropine ointment with less than a size of a grain, not more than a size of a grain. Like we say that चावल के दाने से भी हल्का ointment लेना है और बच्चे की inferior fornix में apply करना है दिन में 3 बार 3 दिन के लिए, and follow up after 3 days. And the mother is also advised that if the child develops fever, redness of the skin, or the rapid pulse, the drug should be discontinued at once, and the child should be referred to any pediatric health facility. Cyclopentolate, it is faster cycloplegia with rest residual accommodation, commercially available as 0.5%, 1%, and 2% solution. It is a drug of choice for routine cycloplegic refraction for routine in nearly all the age groups. Faster onset of action, shorter duration of effect, equally effective as atropine in case of older children. Full recovery of mydriasis and cycloplegia occurs within 24 hours. Cycloplegia occurs, as I said, at least 1 hour or 45 to 60 minutes after the instillation. Scopolamine or hyoscine. This is not routinely used and not commercially available for the ocular application, although dermal patches are used for motion sickness. It is contraindicated in small children, young children, because it easily crosses the blood-brain barrier and causes CNS effects, convulsions. We should take precautions and special considerations in elderly patient, Down syndrome, and young children, although it's not relevant because it's not commercially available. Phenylephrine, as I already mentioned, that it is alpha adrenergic agonist, which works through the neurotransmitter noradrenaline via these sympathetic pathway. It it is the agonist of the alpha adrenergic receptors, which cause stimulation of the dilator muscles of the iris and causes mydriasis. And it is not cycloplegic because it does not paralyze the ciliary muscles. It is available in 2.5 and 10% solution. 2.5% phenylephrine is routinely used in combination with tropicamide, as I already told you. 10% is seldom used, and when it was useful for breaking the posterior synechiae, and majority of the side effects are associated with 10% solution used. It also causes the vasoconstriction of the smooth muscles of the conjunctival arterioles, So causes the blanching. And this is the other reason why it is used in combination with the tropicamide, because tropicamide causes congestion if you use plain tropicamide. But when you use the phenylephrine combination, it aids in the mydriasis as well as it causes the blanching. So increases the patient comfort. It also has a transient effect on the Mueller muscle. It causes stimulation and causes the transient widening of the palpebral aperture. Maximum mydriasis occurs at the 45-60 minute duration and can last up to 6 to 7 hours after the application. Risk and precautions are like it has a risk of adverse cardiovascular reactions frequently reported with the 10% solution. Should be used in caution with patient with cardiac history, definitive history of cardiac diseases, orthostatic hypotension, hypertension, and advanced arteriosclerosis. Also contraindicated in patient taking the MOA inhibitors, tricyclic antidepressants, and drugs like methyl dopa, which is commonly used for Parkinson's. So the crux is you always start with the good history, take visual acuity, see the direct and consensual light reflex, document that, then see the anterior chamber depth by the torchlight examination, do the slit examination, see whether there is any anterior chamber lens, iris fixated lens or not, then explain the procedure to the patient, be considerate to the patient, explain about the side effects of the Mydriatic and cycloplegic you are using, and then gently, following the good practice protocol, retract the eye, tilt the head, put the drops in the inferior fornix, and be gentle and empathetic during the whole process and wear the smile. These are the take-home messages from my side. Now, I thought that this is a great opportunity to add two more special conditions. Being an optometrist, you will be exposed or may have already been exposed to the assistant to the dilated examination for ROP screening. And there is a very much confusion that which mydriasis mydriasis should be used for these small premature children. So this table shows that phenylephrine, cyclopentolate, and tropicamide can be used. And data in neonate shows that these drugs can cause increased mean arterial pressure, cause CNS depression, and have many side effects. So what drugs should be used? And these are two drugs combination which are evidence-based. The studies are mentioned for your references. The combination of phenylephrine 2.5% and tropicamide 0.5% drop is very effective and safe Mydriatic combination for use in premature children during ROP screening. But the side effects of Mydriatic drop may be more common in children having systemic disease, respiratory distress syndrome. So these babies should be kept under observation. Otherwise, this combination is, I think, very feasible, commercially available in India, and should be used for routine ROP screenings. Other prepared combination is of cyclopentolate 0.2% and phenylephrine 1%. And they say that it appears to be Mydriatic for choice for preterm infants with dark iris. But it is not feasible because this combination is not commercially available. So focus yourself on this phenylephrine 2.5 with tropicamide 0.5% drop. Other special circumstances is Mydriatic in pregnancy. We all know that indications in pregnancy are pregnancy-induced hypertension, gestational diabetes mellitus, CSR, and in fact, macular edema is much more common during the pregnancy. And those who work in a hospital setting, they may find that referral comes from obstetric department routinely for the fundus examination of the pregnant female. So this table shows the FDA drug risk classification, and it is applied to every medicine used in medical science, not only these Mydriatic and all ophthalmic drugs. That the group A and schedule B drugs are usually safe. C are dicey, and if the therapeutic benefit overweighs the side effects, you should use C. The D is dicey and more in favor of not using, and X schedule are completely contraindicated. Unfortunately, the combination of tropicamide and phenylephrine as a mydriatic can be safely used in pregnancy. And in every trimester, like first, second, third trimester, you can easily dilate the pregnant female with combination of this drug. And this is a review article named Ophthalmic Consideration in Pregnancy. You know, I just found this article very much interesting. And during the preparation of this slide, I find this article. And I urge you all to, you know, go through this article, not only for the mydriatic and cycloplegic, but for all the ophthalmic drugs which will you will be, you know, encountering in your clinical day-to-day clinical practice, and it is very useful for your clinical practice. So just take a note of this. Thank you very much for your kind attention, and this is my email ID for any comments, any suggestions you want to, any feedback if you want to give about this presentation, you're most welcome to mail me. Also, the Instagram and Facebook, I'm very fortunate to have many of the optometrist friends from optometry fraternity, friends and colleagues. So you're most welcome. And this is slide of Manthan Eye Healthcare Foundation. You can volunteer with us. You can go to this website, mehfindia.org, if you want to know more about it. And one of the vision for this year and coming years and years have passed is the eye health education and training for optometrists. And with our MOU with the Ansal University, we are pledged to increase and build, enhance the training for the optometrist, future optometrist. And I want, this is my vision that optometrist fraternity should learn the next upcoming batches of the optometry should be very, learned. They should be, education gives you self-confidence. If you have knowledge, then you can face any clinical challenge you have. But if you have no knowledge and it's just like that, okay, hame dilate hi karna hai, hame piche rehna hai, then nobody can save you. You have examples of legendary optometrists with you. Mr. Ajit Bhardwaj, Professor Monica, Rajesh Vadwasar is there. So these individual motivates me to study, to gain knowledge. And this is my passion, that optometric training and education should be uplifted to make optometric profession future bright in India, like US, UK. And I found that working in UK, I found that the potential in our student is much more than the potential at the UK thing, but optometrist there, here I found the basics are more strong, but there is a need to refine them to make them more this thing. And my subject under the ophthalmology, which I am very much interested, are diabetic retinopathic screening, glaucoma, and public health. So we are in the stage of developing many modules in association with Ansal University, and those of you who are interested to join the course may contact Professor Monica Chaudhary for further information. Thank you so much. Over to you, Mr. Oli, and we can start the discussion.
Thank you, sir, for your wonderful presentation. We wish to go ahead with the question and answer session, and followed by Ajit Bharadwaj sir will give you a vote of thanks and future announcement. So coming to the first question from Mr. Jatin Rajput, how to decrease scattering of light, blurring of vision in patients with naturally large pupil?
Okay. This is a very good question, and we see that many patients complain that they have, especially after the cataract surgery, if the there is injury to the iris, and the sphincter tear is there, so the pupil is dilated. So you can use the tinted contact lens, which comes under the domain of the optometry only. You can, if the glare of the is very much disturbing to the patient, you can give the tinted contact lens. And I think the most important thing is the cost. If we see the cost benefit analysis, the dark goggles may work, and apart from that there is no other way. Either you can prescribe them with the dark goggles, and if the patient still complains, you can go ahead, and if the patient can maintain and afford the contact lenses, you may go ahead with the contact lenses. But if it is very much disturbing.
Thank you, sir, for the wonderful explanation. Coming to the next question from Mr. Soumik De and Ramya Natarajan. I think you already got the answer for the ROP screening protocol and the medicine combination. The question to sir, what is the commercially available brand name without any financial disclosure? They wish to know.
If you find any of the tropicamide plus phenylephrine combination, they comes, if you see carefully the bottle or the vial, like Tropicacil Plus or Tro Plus, again with no financial interest, they have 0.8% tropicamide and 2.5% phenylephrine. So it's very much close to the, anyways, very much close to this 0.5 and 2.5. While what we were using is not actually and currently not available in India. It was available in UK, but in India, what we used to do, that if we find the child has respiratory distress and very much premature, and we don't want to take any risk, we dilute this combination of 0.8 with 2.5% with a lubricating eye drops. And it's a guesswork, it's not a complete this thing, but if you take out around a few ml, 2-3 drops of this dilator drops, and put the sterile lubricating eye drops, it will work. It will make it as a concentration of 0.5 with 2.5%, maybe 0.5 with 2.3%. And basically, if you just very much particular and stringent about very careful putting one drop, so this 2.5 plus 0.8 combination will not do any harm. You can safely use that.
That was great, sir, for the explanation to make it how to make ROP screening drops available. Now, continuation with the same question from Ms. Sweta Paul. What if the child shows allergic reaction to it? What are the options available for us?
Okay. See, when you do ROP screening, the standard operating guidelines say that you cannot do ROP screening without a presence of a pediatrician. So, because when you do a ROP screening, you nest a child. The process of covering the child is known as nesting, and then you put a wire speculum to the child, then put a drop. So the pediatrician is always available. If the child develops any signs of respiratory distress, because when we put the wire speculum, there is a chance, also the chance that patient can go into vasovagal syncope. So we always use Paracane first, then put one drop of this Mydriatic drug, and you don't have to worry, because the pediatrician is always there. You cannot do a ROP screening without a pediatrician, and if a child develops that kind of allergic reaction, you have to stop the procedure, and then the pediatrician will carry on the next further step, giving the anti-allergic drugs to the child. Now your work is done at that point of time.
Oh, thank you, sir. Coming to the next question from Mr. Soumik once again. Is it myth or fact about not to use tropicamide plus component in patients with diabetic or hypertension?
I don't find any. I think it's a myth because we can very well use a combination of tropicamide and phenylephrine in a diabetic patient or a hypertensive patient very much safely, because I've already told that the 10%, if we use the 10% solution of the phenylephrine, it is kind of contraindicated and you should be cautious. As well, as far as the 2.5% combination is concerned, you can very well safely you can use it. There is no contraindication.
Great. Coming to the next question from Mr. Anurag Singh.
Sorry, Ollie. And if I want to just stress on a point that if you are, very much concerned that the patient has recent bypass or the patient has been a sign of ventricular tachycardia, PSVT, etc., to be very sure, what you can do is just put a 1 drop of this tropicamide phenylephrine combination and tell the patient to close the eye or do the punctal occlusion to prevent any systemic absorption of the drug, right? So these practice should be followed with that particular patient.
Great, sir. Thank you for the explanation. Coming to the next question from Anurag Singh Tomar. So why dilatation is contraindicated in patients with previous head trauma?
The statement says that you have to be very careful if the patient has head trauma before dilatation, because the head trauma patient, if you have subdural hemorrhage or some if the patient has hematoma pressing upon the brainstem or these kind of brain structures, the pupillary signs are very important. That if the patient is already dilated, then it is a very much important sign for anesthetics or an intensivist. He should first see the patient and see if the pupil are dilated. That then it is a very grave sign. What happens sometimes in my own clinical practice, when you see the ocular emergencies like trauma, you just go when you are like especially a PG, and you just before going you just tell the doctor or emergency GP to just put the dilator drops. That should not be done. When you are encountered with a trauma patient, go and first see, document the pupillary reactions. Then if you find it's not contraindicated, but you have to be very cautious, because you cannot dilate. If you dilate, then it would be very confusing state for the anesthetist, that ICU doctor, that whether the pupillary reactions were noted or not noted, if they were dilated or not, then it will create a problem. It's not contraindicated, but you have to be very cautious. That was the point I wanted to make.
Thank you, sir, for the explanation. Now, next question is from Mr. Jaffer. He wished to know, is the contraindication for dilatation limited to closed or narrow angle glaucoma, or even for other glaucomas?
This is very interesting question. I think this should have been asked. It is definitely contraindicated in angle closure glaucoma. If you see on Von Herrick's or by your own experience that if the angle are closed, then you should refrain from dilatation. And if the patient history is not known, then it's fine. You don't know whether it's a primary open angle, maybe open angle glaucoma or whatever. But if you know that the patient has primary open angle glaucoma, then please refrain from dilating, because the studies have shown that in primary open angle glaucoma also, the mechanisms are not known, though the dilatation with tropicamide and phenylephrine may exacerbate the increase in IOP. Okay, and I would take the opportunity of this question to explain one more query that maybe can arise in the subsequent discussion. That there is a tendency that when you are new in a health facility, or maybe you don't know and inadvertently you just dilated the patient who was angle closure, let's say, then what should you do? You have put in the dilator drops, and now you know that by mistake you have done. then what the smart optometrist or the smart ophthalmologist will do, that he will report to the senior. And the over smart ophthalmologist or trainee optometrist, what he will do, he will say, oh, let me put the pilocarpine into the eye. If the Mydriatic can dilate, the pilocarpine will constrict the pupil. Never ever do that. Because, you know, the completely dilated pupil is much more safer than the mid dilated pupil. I don't want to go into the in-depth discussion that the vector forces which act on the pupil when it's mid dilated, it's very, very dangerous than the fully dilated. Never ever put pilocarpine, you know, in order to hide your mistakes. What you should do, that if observe the patient, ask the patient to wash the eyes, observe the patient, keep patient with you. If the patient develops any signs or symptoms of increased intraocular pressure, report your senior, give Diamox to the patient, and manage as a case of acute congestive angle glaucoma, like give mannitol, or what are the, you know, other protocols, estazolamide first, then mannitol, and subsequently you will able to manage. And other reason of not giving the pilocarpine is, first, it will make the scene worse by giving the mid dilated pupil. And other thing, in the case of acute congestive angle glaucoma management, pilocarpine is not indicated during the first few hours, because the infiltrated or the ischemic pupil does not respond to your pilocarpine. You should start with the other beta blockers, start with estazolamide, mannitol, and then when the IOP decreases, ischemia on the ocular structure decreases, then you can give pilocarpine. So thank you for the audience for asking this question.
Thank you, sir, for this wonderful insight and explanation on this. Now, coming to the next question from Ms. Aishwarya Mahapatra, she would like to know, are there any specific indication or precaution we need to take for patients with tuberculosis?
Tuberculosis patient, no. As far as the cycloplegic Mydriatic is concerned, there is no such contraindication, but you should be, you know, you should be careful with tuberculosis patient, that wear mask, put mask on the patient face, put mask on yourself, because when we do direct ophthalmoscopy, we are, you know, very much in proximity to the patient. In fact, in the slit lamp also, we just confront the patient with so much proximity. So as far as that precautions are concerned, yeah, maintain a distance, use personal protective equipments. But as far as the Mydriatic cycloplegics are concerned, no contraindication, nothing.
Coming to the next question from Optum Ajit Limaye, sir. He used to know the long-term side effect for 0.01% atropine, as is being used for almost common in myopia progression nowadays.
Thank you, Mr. Ajit Limaye. This name is very familiar. I think we met in the Gravity conference. Thank you, sir, for asking this question. As far as the low dose atropine is concerned, see, everything in ophthalmology or the medicine is evidence-based, sir. And the recent study, which was, I think, ATOM 2, came in 2012, says that the very low dose atropine, if we use for 1 to 2 years, has no side effects as compared to the high doses like 1% or 0.5%. But these studies were mainly done in the Singapore and Singaporean eyes and in the Chinese eyes. I think in India, we have to be, you know, we are lagging behind in the evidence base. And I know that like from last 3 years, many studies have been undergoing, and a famous pediatric ophthalmologist from Mumbai, he is also doing studies on this atropine, and I know some people in Shroff Eye Center, Delhi, also using that drug. In fact, I have a follow-up of a year. From 1 year, I have been prescribing this drop to a child, and I don't find any side effects till now. So in my practice, small experience without any evidence based in Indian eyes, there is no side effect. But I think all more randomized control trials like ATOM 1 or 2 should be done in Indian eyes. And I think we should, before embarking upon any consistent or validated answer, we should have to wait.
Great, sir. Next question is from Ms. Supriya Patil. She used to know, are there any synergistic effect of paracaine to dilate faster
Yes.
in conjunction with?
Yes, I've already explained that apart from the patient comfort perspective, there are some changes in the epithelium of the, basically they denude the epithelium of the conjunctiva and aid the permeability of the drug in subconjunctivally. So it aids actually in, although it does not have any direct effect on the dilatation, because it does not affect the autonomic nervous system, the parasympathetic or sympathetic, but it aids in the permeability of the Mydriatic drug for sure.
Great, sir. Next one is from Ms. Roshni Sen Gupta. She used to know role of atropine or homatropine plus addition lenses in pseudomyopia. Which ones to be prescribed?
Sorry, say it again. Role of low dose atropine.
No, atropine or homatropine along with addition lenses in pseudomyopia. Okay. Which one needs to be prescribed?
Basically, for this spasm of accommodation, probably wants to know, do we prescribe and what cycloplegic?
I think Professor Monica, you are the best person for progressive addition lenses. As far as my knowledge says, that yes, if we use, study says that if we use the low dose atropine in association with any other modality of like orthokeratology or progressive addition lenses in the halting the progression of myopia, they have definitely a synergistic effect. But unfortunately, we in every, apart from orthokeratology, the exact mechanism that how these modalities stop the myopia progression, it's very, very dicey. In orthokeratology, we know that it take care of the hyperopic defocus and prevent the axial elongation, stop the stimulus. But for the atropine, we don't know. Many theories have linked it to accommodation. Many theories have linked it to the vitreous and the choroidal, retinochoroidal growth. But as far as the synergism between the two modalities are concerned, yes, they are synergistic. But specifically about the progressive addition lenses, I pass on this question to Professor Monica and maybe Rajesh Wadhwa sir, if you can put a light on this.
She actually wanted to probably know about the spasm if somebody has pseudomyopia, which is actually spasm of accommodation. Yes. So prescribing the cycloplegics in it. It is all case to base. First thing is, yes, we use a very strong cycloplegic to get the exact refractive error. Once that refractive error is there, we prescribe that. Even if plus, you might find a minus kind of dry acceptance and you come into a plus retinoscopy. Visual hygiene vision therapy is a better treatment. You cannot be giving in cycloplegics to young adults and people who have active lifestyles. So it's not the routine that one would prescribe, and it's not a practical routine. Third, you need an ophthalmology co-management if you are thinking about it. We have very well established and handled spasm of accommodation by doing a very good refraction and prescribing the cycloplegic acceptance and visual hygiene and vision therapy. It's most of the time seen in professionals who have too much of near work and they fail to relax their eye for distance. So the simple thing that you have to educate is cut off that, rather than starting cycloplegics, cut off that activity and bring in more visual hygiene to this patient.
Exactly. And I think as far as the pseudomyopia is concerned, many of the times we see that if we use the autorefractometer just for the child accommodates and goes into the accommodative spasm and leads to pseudomyopia, and then the only answer is cycloplegic refraction with atropine.
And cycloplegics, I would also like to just add a practical tip is, we might find that this cyclopentolate, there have been instances in our experience where I've put in cyclopentolate and I realize, yes, this drug has not worked well in terms of accommodation. We may have to add more, or we may have to add something more. There is no replacement to atropine in certain cases, especially the accommodative convergence squints and ESO deviations, but all has to be co-managed. And yes, of course, as you had asked, and we would like Rajesh Wadhwa to bring in that point of where are we standing in terms of legalities of prescribing and using these drugs if we have independent clinics. I think the questions are unlimited in mind, and it simply shows that how much we all have enjoyed your lecture.
See, I'm here. I have no hurry. I would love to answer the questions.
Ollie, we may take up a few more.
Important question, because there is a lot of commonality into it. So there are numerous participants wish to know. There are elderly patient or patient with chronic disease like diabetes or even kidney disease. So they have myotic pupils. So how to dilate them, even though they do not get dilated after 1 year of time? So what is the option for them?
Very, very practical question. And, this is quite frustrating. That's why I added that sometimes junior come to me, optometrist come to me, sir, dilate hi nahi hota hai. Sir, retractor lagaye, kya kare? Sir, kya kare? See, that's why I added that the darkly pigmented eyes, the older age group, the diabetics, they are very much, some pupils are very reluctant to dilate. In my experience, what we do, that the cotton pledget, soaked with these drugs can be put, and if the pupil is not dilating with the tropicamide phenylephrine, use cyclopentolate. It might work, but I'm not, this is not a sure shot. If the pupil decide that I will not dilate, it will not dilate. You cannot do anything. You cannot do anything. See, that is how the challenging cataract surgery comes. Non-dilating pupil. It's one of the challenging cataract surgery. You have to put the iris retractors because it's non-dilating pupil. You cannot dilate it. In fact, many of the these intracameral use, many of the dilators in combination with the lignocaine have come up. But many of the times, if we use that also, the pupil does not dilate. So there is no, it's all hit and trial. Use tropicamide, use cyclopentolate. If it has, the pupil has decided I will not dilate, it will not dilate.
Leave it. Ollie, we may take up some more questions, few of them.
So, to a value addition to the earlier discussion regarding your additional lenses in accommodative spasm. So Dr. Rizwana wished to add some point that if a patient is put on long-term cycloplegics, in case of recurrent spasm, progressive or near addition need to be prescribed. So that was one of the criteria fulfilled. And then coming to the other questions, so I think this already answered why pilocarpine is not advised when you by mistakenly put dilating drops in patient with.
I have already explained, but Ollie, if you want me to explain it again, I can explain it again.
Explained it that there is another process. He's already gone through that. We'll take up the next
one. Sure. So this question is from, I think these are all we have applied. Yes, ma'am. I think we can take a few other questions because from the media and platform, these are all the common questions I have sorted out. And there are many queries and common one.
I think the lecture was so much complete for all of us to see. And I think we need to go back. It was excellently prepared. Thank you, Dr. Sumit, for giving us all that insight. And I think we need to read more. It's not that we can be fed everything. You need to go back. There is so much in cycloplegics and Mydriatics for an optometrist to know. So Rajesh sir, you would like to come up with again the legalities before we ask Ajit sir for his closing remarks and bring in this?
Yes, sure. Thank you, Dr. Sumit. It was really wonderful. And yes, about the use of drugs, AHP bill is a few weeks away now. And the rights for optometrists to use drugs will be dependent on that bill. And one more thing which I would like to add here is that with all these drugs, we all should respect each and every drop of the medication in the little bottle. Let us not overuse. We must know the capacity of the inferior fornix is only about 1/6 of a drop. So do not overuse the drops and spill off such precious drops. And also drugs like atropine, why we are using more of ointment, less of drops, so that the systemic absorption can be prevented, as Dr. Sumit said. But how to dispose of these containers or these bottles left with the if we have given it to the patient has it lying at home, even after the real procedure is over, they should discard it very carefully, wash hands. Atropine is poison, it shouldn't go into food or into mouth accidentally. All these cautions have to be done without scaring the patient. We have to tell them how to discard these. And yes, thank you, Dr. Sumit. Your presentation was clinical and was motivating and has given energy to everyone that there is no end to self-learning and self-improvement, and we should continue improving ourselves. Thank you so much for this. And maybe you did mention you have some award there. Before I pass on to Ajit sir, may I have you in? And,
I didn't find a chat box the correct answer. That was a strategy to get a 2 minutes break to have water and to लोगों को जो हमारे optometry के बच्चे हैं जो especially जो students हैं उनको जगाने का एक तरीका था ये. But Oli, please tell me कि if somebody has answered this question, so that prize will be reserved with me. Definitely.
So there are a number of people who gave correct answers. Before you could explain, it was flooded with the recommendation like punctuation, fever, and the nighttime, rice grain kind of thing. Everything was answered by the participants.
I think you can pick up the fastest finger first then.
Fastest finger and tell me. I'll definitely, the prize, the person deserves the prize and it will be reserved with me.
Sure.
And the next on our next meeting, I would definitely present that person with the prize. My promise.
And there is a flooded messages with appreciation of the talk, and it's like it can be goes in module itself. It can't be covered in a single lecture, but nicely presented so that.
Thank you. Actually, I want to confess that. When I was told to present the lecture, I was keen on taking the ocular therapeutics as a whole. I wanted to sensitize or give a sensitizer to my optometry friends about, especially the student friends, about what are the ocular therapeutics they encounter in day-to-day practice, like antibiotics, antiviral, antifungals. Especially the lubricating eye drops. I found that many of the students are confused between, they don't know what is hypomellose, they don't know what is CMC, what is 0.5%, what is gel, what is the difference between a gentile gel and and what are their indications. They have specific indications like for drop, for CMC, for HPMC, or n number of things. But I found that this Mydriatic and Cycloplegic it's an opportunity to go back and revise and learn. So I just ignored that idea and stick with this. And if we get a provision or a chance in future, I would definitely like to cover the lubricating things, or maybe I request the three of you, ma'am and Vadva sir and Ajit sir, to include that, invite some faculty to talk about the lubricating used in day-to-day practice.
I think Ajit sir, I would like you to sum it up and answer his query.
Can I take one more question? Very interesting.
Okay, we permit you.
Post-COVID scenario, what are the life of this our Mydriatic agents? Are we going to use in a single ampules, or you want to discard after every use? How we are planning to go ahead with this post-COVID?
I think that the best question award goes to this particular person who has asked this question. See, this India is a country where we are like what's the apt word? We use jugaad in everything. And if the haptic is also broken, sometimes we use that lens, although it's very, very much gross negligence I'm talking about. This is not the case. It's not a good example. But we are the people which make use of everything. So I don't think that only a single drop can be used for a single patient. But the coronavirus pandemic has taught us many lessons about our own protection, about the protection of the patient, and definitely that this hygiene and the best practice of using the drops. Like before the pandemic, what we used to do, that touch the cornea of the patient, without head tilting and without proper ergonomics, just banged the drops, sprayed into the patient eye. But this pandemic has taught us what should we should do everything with awareness. Now if a milk packet comes to our house, we just wash it, right? And that would be the best practice with the any drop or any medication use, not only this, that we would be very aware of what we are doing. We have to be very careful. And I don't think that in a low middle income country like India, we can afford to just throw every piece of this thing, because it's not something intraocular. But definitely when in the OT thing, I think many of the measures would be now taken for the ophthalmic practice, and it will revolutionize the hygienic practice, and the use of disposable things will take a boon after this pandemic. I hope I'm able to answer that question.
Yes,
I think so. And I
yes.
think Dr. Sumit, if given a chance, all optometrists would stand in the balcony and one day cheer for you.
Yes. May I invite Ajit Varadha sir to sum it up and announce for the next webinar? Ajit sir, please.
Well, thank you very much, Dr. Sumit Grover, and I really appreciate the way you conduct your talk. It's so informal, and you make it so simple for each one of us to understand the most complex topic on diagnostic and therapeutic. Am I audible?
Yes. Thank you, sir.
Dr. Grover, we'd love to have you again on your favorite topic of lubricant, your diabetic retinopathy work, and on your glaucoma work. And it will be our great privilege that you join us again on one of the next forums in time to come. Really, thank you very much, and appreciate your time, but your argument to us and to optometry profession, which you always are willing to help. Well, coming back to next, why we chose this topic, because these drugs, which we popularly call them DPA drugs, are something which is the stepping stone for optometry. World over, optometrists have progressed first in their refraction skill, in their contact lenses skill, and the third step has been the use of DPA drugs. Any history, any country, the optometry progressed using the DPA drugs as one of the stepping stones. And that is why we decided that these drugs are very important from optometry perspective. And if you look at the today's paper of Indian Express, the cabinet is planning to give a nod to AHP bill. It means the likelihood of DPA drugs may be allowed, but those drugs, those application or those permissions are not going to come so easy. This is the time we need to prepare ourselves that we must learn about these drugs in detail. And we are in touch with various universities to come out with a kind of certifications, a kind of maybe a certificate course, a diploma course, whereby we can certify them to have an official kind of exam for them, whereby they are pre-certified before the registration come in. Coming back to our next speaker, we will continue to work with you in upgrading the skill of our optometrist. At the same time, we will continue to protect our profession from the anti-quackery, the quackery which we're having in the field of opticianry. We know that there are so many opticians which are infringing on rights of optometry and prescribing glasses without even going to even a secondary school or without even going to any optometry school. And this is what the two things which we are working on: upgradation of skill of optometry and protecting ourselves from the quackery. And We love to see the way optometrists come and participate in our events, what we are conducting, the webinars which we have been conducting so far. And to supplement this, our next speaker, Dr. Rashmin Gandhi, is a really well-read person, a doctor who has done his FRCS from Edinburgh, FRCS from Glasgow, and he did his ophthalmology training from John Hopkins. And we're glad to have him next time, and he will tell us about how to assess the pupil, how to do RAPD, how to detect neuromuscular anomalies, and how to assess a pupil when a patient has paralytic state. So I'm sure that's the topic of great interest. And thank you, Dr. Sumit, and thank you all audience for getting our numbers increasing day by day. And that helps us to keep motivated to bring better and better speakers for coming webinars. Thank you again. And I think over to Oli to close.
Thank you.
Thank you all of you for your wonderful engagement, and not to wait for more time. We are waiting for the next lecture, Dr. Rashmin, and day after tomorrow. Thank you, Sumit sir, for your wonderful explanation and presentation. We look forward to hear you very soon. I would request the chairs who are there should arrange another session with you on the ocular therapeutics. We are looking forward to connect with you all day after tomorrow, 6 p.m. Till that time, goodbye. Thank you.
Thank you. Thank you.
Thank you, Ollie, for coordinating it also.
Thank you so much, Ollie. Thank you.